Thank you, Chris, and welcome everyone to Headache School. I'm Dr. Kathleen Digre. I'm a distinguished professor of neurology and professor of ophthalmology, and I'm really excited to talk today about what do I do with my headache in pregnancy? Pregnancy is such a special time of a woman and a family's life, but when you have headache or migraine disorder, you want to know how to navigate this. So the first point that I'm going to make is that all women of childbearing age should think about pregnancy if they have migraine. Many of us have had unintended pregnancies and carried them through, and it's important that we think ahead of time, think prospectively. Is our migraine, is our headache well controlled? Is it diagnosed properly? Are we knowledgeable about medications that we're on? And if we get pregnant and we're not expecting it, do we have any problem with the medications we are on? All women before pregnancy should consider folate supplementation. This is a vitamin, folic acid, which is very important for the development of a baby. And also, if our vitamin D is low, we may need to be on something like that before we even get pregnant. And also consider prenatal vitamins, since women of childbearing age can often be anemic and need extra vitamins. So if you're thinking about pregnancy at all, even if you're not, if you're of childbearing age, you should at least be thinking, have I optimally controlled my body for a pregnancy that could occur? So I'm going to start with a woman. This is Elisa, who is 32 years old, and she's pregnant for the very first time. We call that Gravida 1, and she's had chronic migraine. And she presents an early pregnancy asking for counseling about how her migraines will change her pregnancy and what are her risks during her pregnancy. So we're going to take this case and try to help Elisa understand what's going on. Well, the first thing that we have to understand in pregnancy is that migraine aura can actually begin in pregnancy, and also it seems to be related to the increase in estrogen. So these are just basic facts. About 17 to 20% of all women have underlying migraine. About 92% of those women will have resolution of their headaches usually after the first trimester, which is like after the first third of the pregnancy. But there are 8%, 8 to 10% who can have worsening during their pregnancy. So it's important to understand whether you're going to be in that group that actually gets better with pregnancy or maybe has more problems during pregnancy. And this is really this graph shows us that first we'll take estrogen. In pregnancy, our estrogen increases steadily as we are pregnant, and progesterone also, the red line, increases steadily. And please note that in each of these trimesters, you can see how frequently the migraine gets better, either goes away completely or gets better. So in the first trimester, maybe half of the people will get a little bit better. And then in the second trimester, way over 3/4 of the people will get better. And by the end, it's in that same, almost 90% of people will have improvement of their migraine. And we think that this may have to do with hormonal shifts, but there may be a lot more things going on than what we understand. So most women get better, 60 to 70% get better in the second and third trimesters. That's in the second 2/3 of their pregnancy. And only 4 to 8% of women experience worsening of their symptoms. It's interesting, however, that maybe 1 in 10 people actually have their migraines start in pregnancy. And that could start with an aura, or just start with a headache, and a migraine occurs. And the pre-pregnancy headache pattern returns usually after delivery. So in other words, let's say Alicia's having migraine 15 days a month. In her pregnancy, she's got a very good chance of having her migraines go completely away during her pregnancy. And then after she's done being pregnant, after her delivery, the pattern could start to return to that chronic migraine. We know that women who have fewer children have fewer headaches. And as a woman has more and more children, they do get more headaches. Now, you might say, well, is that just because they're stressed out or because they have to take care of children? You know, understanding that piece of it is not completely clear, but it's very clear that the more pregnancies somebody has, the more chance of them having more headaches. The best predictor of the headache outcome is what were the headaches before the woman got pregnant. So that's why I said it's really important to have a handle on headaches before a woman gets pregnant. Now, it's interesting that headache itself can have an effect on pregnancy. So women with migraine can have a 2 to 3 times increased incidence of preterm birth. And that's just a statistic that's been shown. It doesn't mean everybody does, but there is a higher chance of having a preterm birth. The other important thing is migraine may be associated with an increase in blood pressure, and this has been shown as well. And women with migraine have a higher risk of a condition called preeclampsia. This is a condition seen only in pregnancy where the blood pressure goes up, the woman spills a little protein in the urine, and this is a high-risk situation that needs to be monitored by a high-risk obstetrician. Now, treatment of headaches in pregnancy begins before a person is pregnant. So we call that pre-conceptual planning. We want all women who intend to get pregnant to have preconceptional planning. And that means that they talk to their doctor about how they can optimize their care and their headaches before they even get pregnant. And remember, I said all women of childbearing age should probably be on folate, which is a vitamin that helps with the neurologic development of the baby. And then all women who are planning to get pregnant and who are pregnant should work on healthy lifestyles, sleep, getting enough rest every night, having a well-balanced diet every day, and having regular exercise every day. We don't need to push to not use medication. We want to really focus on those lifestyle things and then avoid things like alcohol and nicotine for anyone who's planning on getting pregnant, and for sure anybody who's pregnant. And then we want to focus on things that really are not medication, which is like biofeedback, relaxation training. So skills that can be learned even before a person gets pregnant. So I think these life skills are so important for every woman of childbearing age to know, to be able to practice when you get pregnant. Now, when we talk about medications, there are different classifications about drugs. And the Federal Drug Agency that works on classifying all medications in pregnancy had an old system called the ABCDX. A meant that that medication was perfectly safe, just use it with however you want. Well, there are almost no medications that have A level. B is probably very safe. It's been studied in animals. It's been studied in people. There's really no major problems. An FDA C classification is the safety's unknown in humans, but has been pretty well studied in animals, and we think there are no known birth defects with it. An FDA D grade means don't use it unless you really need it, and there may be definite reports of harm. And an FDA X classification was don't use it under any circumstance because it can cause birth defects, or it can cause a miscarriage, or it can cause a problem in the pregnancy. Now we try to classify drugs as what are the preferred treatments, and I'll show you how this works. There's second-line treatments, use only if necessary, and again, this don't use. So the classification is really changing, but this is a kind of a simplified version. But I want you to understand that all drugs kind of have a classification of use. Now, I'm going to divide medications into acute headache treatment, and I'm going to talk about non-triptans, and then I'm going to talk about triptans. And those of you who have migraine know that we've got those kinds of medicines available. Now, I'm also going to divide it into grade A evidence, grade B evidence, grade C evidence, and unknown. Okay, but I'm going to start with the highest level of evidence in non-triptan medicines. So acetaminophen, Tylenol, is the name that many of us know, is actually a class C, but it is a preferred use because it's used ubiquitously during pregnancy and thought to be very, very safe. Metoclopramide, Reglan, is a anti-nausea medicine, but it has some effect on migraine all by itself. It can be used orally or intramuscularly. It has a FDA class B, and again, it's preferred use. Diphenhydramine, also known as Benadryl, often is used in pregnancy for sleep with a bad migraine. It's got a C classification, and again, it's in preferred use. Dihydroergotamine and all ergots have great evidence, but they are an X drug. We do not use these in pregnancy because of untoward effects in pregnancy. So we do not use this drug in pregnancy whatsoever. Some of the non-steroidals like ketorolac, also known as Toradol, naproxen, known as Aleve, ibuprofen, known as Advil, all are C drugs. They can be used in the second trimester, but not in the third trimester because they can cause harm to the developing fetus by closing up a ductus arteriosus. It's a part of the heart, and closing it up too soon can cause trouble for the fetus. So we only use those drugs in the second trimester. Now, if we look at grade B evidence, non-triptan drugs, there are other medications like chlorpromazine or Thorazine, promethazine or Phenergan, prochlorperazine or compazine, all FDA C drugs, but they can be used in pregnancy. We don't use DHE at all. And magnesium sulfate, while it is used in pregnancy for preterm labor, it can be used for preeclampsia. It's been given a FDA D class for use for migraine in pregnancy. The best evidence is for the triptans: sumatriptan, naratriptan, zolmitriptan, elatriptan, rizatriptan, frovatriptan. And in a big, large meta-analysis, and that just means that they brought all the data together, and they analyzed 4,200 infants that were exposed while a woman was pregnant to a triptan. And they compared those children to over 1 million children that had no exposure whatsoever. And there was no increase in any major congenital malformation or prematurity. So really, many obstetricians and headache providers are looking at triptans as a first-line treatment for migraine. And they're the most efficacious for most women in migraine. A drug that many people have used in pregnancy that has butalbital, a barbiturate, sometimes known as Furoset or Furanol, that if it has aspirin, has actually been shown to have a congenital heart defect risk higher than triptan. So it can be 3 times higher. So we tend to avoid the butalbital compounds in pregnancy. Now, opioids have often been used in pregnancy thinking that they were very safe. However, now when they've been doing large national birth defect prevention study, they found that opioids used before conception and in early pregnancy had a higher rate of heart defects and also spinal cord abnormalities that you don't want your baby to have. Not to mention the maternal mortality rate with the overuse and abuse of opioids in pregnancy. So we really want to avoid opiates if we can in pregnancy. Now, one acute treatment that has been looked at in pregnancy in some very small studies is an occipital nerve block. These were used in women who failed an oral treatment for their migraine. 38% of these individuals had chronic migraine. Over half of them were in what we call status migrainosus, meaning that their migraines were just coming and coming and coming, and they couldn't get rid of them. 11 had acute pain relief, and that is pretty good. 11 out of 13 people got really good benefit from the injection. 2 did not get pain relief. The medicine that was injected with these needles, and you can see on this diagram where they injected the medicine, lidocaine is an FDA B drug and bupivacaine is an FDA C drug. And it's used in dentistry, anesthesia, for obstetrics. So it's generally thought to be very safe. Now, one of the new things we've used for acute migraine has been devices. Now, these devices you wouldn't want to use in anybody, putting some device on your head like that, or in this cartoon painting shows a doctor from the Middle Ages actually drilling a hole in this man's head as a device for stopping a migraine. But we have many better devices these days. So we have a device that you wear on your arm, which is called a Nerivio device. We have transmagnetic stimulation, another external device, a vagal nerve stimulator, and a supraorbital nerve stimulator. All of these devices have been used for acute migraine, and many individuals prefer these devices in pregnancy. There's not a lot of data in pregnancy, but most people feel that these devices are probably very safe since it's not any ingestion that's going on during the pregnancy. Some people have tried sphenopalatine ganglion blocks. This is a block where it goes through the nose. It's been described for over 100 years. Use a topical anesthetic like lidocaine. And then there are many different devices that go up the nose or a cotton swab that can anesthetize that ganglion and stop the migraine from occurring. So these are blocks that also have been looked at. So those are acute treatments during pregnancy. What about prevention? So prevention is really where it's at often in when we are taking care of our patients. We want to prevent the migraine from occurring. And once again, I'm going to bring up non-pharmacologic treatments. I'll also talk about medications that you would take daily. I'll talk about injectables, and I'll go to the devices that have been approved for prevention. I can't stress enough the non-pharmaceutical prevention that we do with lifestyle modification, meaning eating a good diet every day that's balanced, avoiding sugar and a lot of carbohydrates, getting adequate sleep every night. A pregnant woman needs sleep every single night, 6 to 8 hours at least. Daily exercise, even if it's walking every day. One needs to gain weight, but you don't want to gain too much weight, since that can also be a problem. And then limit caffeine use in pregnancy. Now, when do we offer preventive medications? Well, we know that if you have more than 6 headache days a month, we should think about using a preventative medication. If we have 4, but we are mildly impaired, we should think about a preventive medication. If we have 3 and are severely impaired, we should think about a preventative medication. So what medications can we talk about? And so again, I'm going to tell you first about evidence, which is grade A evidence, means we've got really good evidence for the work. B evidence is we've got pretty good evidence, but not the best. C is we do have evidence, but it's not perfect. And U is we don't have as much evidence. And then I'm going to give you the pregnancy classification by the FDA of A, B, C, D, X. And then I'm going to tell you if it's preferred or not. So first, propranolol is a grade A evidence. It is a C class, and it is in that preferred category. And propranolol and metoprolol are both beta blockers in that preferred area. A drug that has very good evidence is an X, meaning we do not use this in pregnancy because it's known to cause neural tube defects. So do not use that drug in pregnancy. Topiramate is D. We only use if it's absolutely necessary because it too has evidence of cleft palate, and so we try to avoid it. There are other beta blockers that have grade D, or FDA D, FDA D, but have pretty good evidence for them working. Amitriptyline is a wonderful drug that we still use in pregnancy. It's second line, but it's pretty safe and used for a long time. As is venlafaxine, which is a serotonin reuptake type inhibitor. It's an FDA class C, but it's pretty safe and is used. Cyproheptadine is a drug, a very old drug. It's got a B classification, meaning it's pretty safe to use. It does have weight gain as a potential side effect, but it is a pretty safe drug to use in pregnancy. Verapamil, gabapentin are C drugs. We just don't have enough evidence for their use in pregnancy. Now, the new medications are the CGRP monoclonal antibodies. We don't know. All of them are listed as C drugs, but because we don't know, we are not recommending their use in pregnancy. There is some hypothetical data that it could increase the risk of preeclampsia, that condition of high blood pressure in pregnancy. So right now, it's unknown whether these can be helpful in pregnancy or not. Onabotulinum toxin, or Botox, has been studied a little bit. It's an FDA C drug, and some people claim, and there are reports of its use in pregnancy, of its safety. We don't have any major negative parts with that, but again, its safety is unknown. I talked about the occipital nerve block as a preventative. It's got level 3 evidence, but it is safe. Sphenopalatine ganglion block as a preventative is probably safe. Trigger point injections with lidocaine, which is an FDA B drug, as a preventative. These all have not the best evidence that they're very efficacious or helpful, but they are probably very safe. Now, there are devices that are used for prevention and migraine, and these devices, I already talked about this external stimulator on the arm, the transmagnetic stimulator, the supraorbital stimulator, and the vagal nerve stimulator. And many people are using these devices more in prevention for pregnancy because it does not involve ingesting a medication. Now I'm going to switch gears to postpartum. So that's the information about treatment in pregnancy. And I think you heard me loud and clear. Lifestyle is really diet, exercise, sleep, stress reduction, all are extremely important before pregnancy, during pregnancy, after pregnancy, and that's the same for postpartum. Now, the postpartum, basic understanding of headache postpartum, headaches can return to your primary headache level. So if you had chronic migraine before you got pregnant, I have to tell Elisa, we want to be very careful that we don't go back to chronic migraine postpartum. Sleep deprivation, which happens when you have a new infant, is a big trigger for a lot of women. And so working with the woman and her partner is extremely important, that we say, listen, this is a team effort. This woman needs sleep. We need to get regular sleep to help prevent headache. And there is, in the postpartum period, an increased risk of secondary headaches. And I'll talk a little bit about that as well at the end of this talk. And a secondary headache is a headache due to something else. But what about lactation or breastfeeding? So there are books out there on medications and mother's milk, and there are lots of conflicting evidence in lactation about medications. Migraine itself is not a contraindication to nursing. There's no reason not to nurse if you have migraine. You can nurse, and several triptans are considered by the American Association of Pediatricians. And those two are sumatriptan and zolmitriptan. They've been studied and they found to be safe. There are also several preventative medications that are considered safe. But any drug you give to the mother, you have to look at the dose of the drug. You have to know if it's excreted in milk and whether it's lipophilic, meaning it's fat derived, or if it's protein bound, and does it cross into the milk? And, you know, every drug has different profiles, so that every drug you have to actually work at finding out whether a drug can be used in lactation. At the University of Utah, we have a wonderful service through the pharmacy that you can go to and actually find out answers to these questions. And asking a pharmacist can help you with any medication that you want to be on. But I would say talk to your provider about medications for this. Now, acute treatment and lactation, things with proven safety is like acetaminophen, Tylenol, ibuprofen, elatriptan. Caffeine itself is pretty safe. Prednisone, we don't use that very often. And then these dopamine antagonists, things like promethazine, Phenergan, and compazine are safe in lactation. We still don't use ergotamines in lactation because it can be transferred into milk. Now, so lactation is complicated, and my recommendation would be to talk with your pharmacist about lactation and the medicines that you want to be using for headache prevention after you're done being pregnant. Now, pregnancy can be associated with secondary headaches. Now, what is a secondary headache? A secondary headache is a headache that comes from something going on in the head, like a tumor or a stroke or something else happening in your head. And this chart shows you that most headaches in pregnancy and after pregnancy, most of it is migraine. Almost everybody, that's the major cause of any headache in pregnancy is going to be migraine or tension headache or chronic tension headache, but you know, that's the majority. Blood pressure disorders are the second most common cause of headache during pregnancy, after pregnancy, like preeclampsia. I've talked about preeclampsia, eclampsia, etc. And then there are things like having a stroke in your pituitary gland, having a venous sinus thrombosis, or having a hemorrhage in the brain, or some other cause. But these are rare, okay? These are rare. But of course, we want to make sure that every woman who has a headache has the correct diagnosis of a primary headache disorder like migraine or tension type headache. The secondary headaches that providers are going to look for, the one that is significant, especially postpartum, is venous sinus thrombosis. and then severe preeclampsia. And these can happen postpartum, and they can happen during pregnancy too, but many of them can happen postpartum. Also, reversible cerebral vasoconstriction syndrome, which is a thunderclap onset headache, is a secondary headache that can happen after pregnancy and during pregnancy. It can happen in response to certain drugs. And so but it's not very common. And then pituitary apoplexy does happen in pregnancy or postpartum because a woman's pituitary gland enlarges during the pregnancy, and that's when the time to have the hormones increasing to keep the hormones going during the pregnancy, and also to provide extra prolactin, which stimulates lactation or mother's milk. So those are the kind of the danger. They're not common, but they can occur during pregnancy or postpartum. I do want to mention that preeclampsia is more common in women with migraine. So you want to tell your provider you've got migraine so that they are on the lookout for preeclampsia. And that risk can go up if the headache keeps persisting. There's also a very small increased risk of stroke in individuals with migraine, especially migraine with aura. Now, this is a woman who came to me who was 30 weeks into her pregnancy. She had previous migraine, but she started having more and more headache. She was treated for migraine multiple times in the emergency room. Then she started to lose vision, and these are her optic nerves, and these are not normal. These are swollen optic nerves. When we looked in the back of her eye, we could see that she had swollen nerves, and she had a venous sinus thrombosis. And so when you see the swollen nerve in pregnancy, that's why people look in the back of your eyes to make sure you don't have a swollen nerve. You have to think about mass lesions like a tumor, increased pressure, which can be primary from idiopathic intracranial hypertension or secondary due to venous sinus thrombosis or due to eclampsia, meningitis, or many other causes. Idiopathic intracranial hypertension can occur in pregnancy. This condition is seen in women of childbearing age. It's seen in obese women, but your doctor can make the right diagnosis by getting an MR scan of the brain, looking at the venous sinuses, and doing a lumbar puncture. And we always follow a patient as if they aren't pregnant with this disorder. We try to limit weight gain, and then we follow the vision. And it's treated with medications like acetazolamide, which is the most common one, but there are other diuretics like chlorthalidone, furosemide, hydrochlorothiazide that are used during pregnancy. In this study, acetazolamide was used safely. They looked at 101 women with intracranial hypertension for a total of 158 pregnancies. And they had acetazolamide usage before 13 weeks of gestation in 50 pregnancies. And there was no increased risk of spontaneous miscarriage or abortion, no major complication in the offspring. So it's considered by this study to be relatively safe during pregnancy. This is a headache problem that I think women who have children and have epidurals should know about. An epidural is an anesthetic that is used during pregnancy when the pain gets severe. Sometimes, and the epidural is put in by a spinal needle, and medicine is put up into around the spinal cord to stop the pain of labor. Sometimes the epidural space, which is outside the spinal fluid, gets nicked into the spinal fluid, and this causes a spinal fluid leak. So this is a woman that came to me after she was pregnant. She'd had an epidural in pregnancy about 3 months before, and now she was having really bad headaches and double vision, and her whole back of her brain was kind of slumping downwards, and that's what she looked like when I first saw her. And then we fixed the leak. And so when I saw her again and we repeated the MR, her brain went back to a normal configuration and she was fine. So that it's just a kind of headache. If you have an epidural and you get a bad positional headache after the epidural, talk to your doctor about whether you could have a post lumbar puncture headache. So what are my take-home messages? If you're pregnant or thinking about pregnancy, I would think about pregnancy and migraine before you get pregnant, because you want to have the optimal control of your migraine, and you want to be on folic acid before you even get pregnant to prevent any birth defects. You want to talk to your doctor, whether it's an obstetrician, your family doctor, or another provider, about you're having migraine, so that they recognize that you've got migraine, they understand migraine, that and most people get better throughout pregnancy, so pregnancy is not a problem. After pregnancy, the migraine can recur to the pre-pregnant level. Always have a plan for preventative measures, and I base them on regular diet, sleep, exercise, and stress reduction. Know what medications you can use both acutely and preventatively safely in pregnancy. And I hope I've given you some ideas to talk to your doctor about, and then consider devices as well. So I'm wishing you very good luck. If you're going to get pregnant, I want to wish you very good luck. And I'm very excited for you, because there's lots of things that we can do these days. And I'll open it up to questions if anybody has any questions.